Please help spread the message of Frequency Specific Microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about Frequency Specific Microcurrent.
Hi.
Where are you?
I'm at a
Post-Operative.
doing good thing. I was like, hurry, Uber driver. I have a very important Zoom meeting I need to get to.
That make it sound like important, and it's no. I gotta talk to Carol.
I missed you so much.
What is up with that? I'm in this beautiful, pristine alpine lake, and it's Wednesday, and there's just something not right with the force. It's
There's like a hole.
Yeah. I know that you were fine and everybody was fine.
I was all set with my wonderful guest, Peter Twist, who was so gracious to give us another hour of his time and to just share a lot of his own journey with his own health scares, getting through cancer and how it changed his life and being present and grounded. And I think that's a podcast that everybody can get some benefit of. Just, we're always so grateful because we both love what we do. And that's not the case for so many people out there who say that they have to go to work. But I think FSM gives us like this new lease on life. And how many practitioners do you talk to at the courses that say FSM, yeah, it changed my practice, but it just changed everything?
When you get to go to work and do magic, reproducible magic. So when I was at this lake, and it was a gathering of friends from Germany and Time Weaver, and there were two people there. One of them said, "Oh, I have carpal tunnel." And I went, "No, you don't." She said, "Excuse me?" And I said, "Here, does that hurt? And does this feel different than that?" Yeah. And then I found her pec minor, and I said, "Does this feel different than?" Yeah. It's your neck. Saturday afternoon and Sunday afternoon, the 2 days before I left, we treated like 3 or 4 patients and ran one machine, my custom care and magnetic converter on disc repair, just 124 and the disc annulus for an hour. And with the Time Weaver, we ran nerve pain and made her arm to under pudding. And then I moved the washcloth up to the pec minor and treated scarring on the nerve, scarring on the arteries, scarring on the vein, and torn and broken in the connective tissue that keeps the pec minor tight. And then scarring on the nerve down her arm. And at the end of it, sensation was normal in her hand, no longer numb. And Tinel's was negative. Next person, exactly the same story, different arm. Concert violinists, like packed, sold out houses in Europe. And so violinist, she said, these fingers cramp. Yeah. And this does that. So you take the, what's that muscle?
So anterior delt and pec major. Horizontal abduction.
And there's a biceps thingy. And so I treated, she's got disc bulges on both sides, but at different levels. So I treated torn and broken on the disc again, and then treated the adhesions in the nerve in her fingering arm, torn and broken in the tendons and adhesions in the nerve in this arm, because the only reason that muscle cramped, like she'd get to the end of a concerto and her hand would just cramp in front of an audience of 5,000 people. It would just be there. at the end of an hour, she said, my chest is open and it doesn't hurt. Yeah, you are not allowed to lift anything more than 5 pounds for 6 weeks, because the number one rule about fixing a disc bulge is you have to stop breaking it. And then there was fourth patient. I forget what we did, but we put all of them to sleep, which was really fun. And to be able to change somebody's life that way in 60 to 90 minutes. And the only way to do that at all is with FSM, because you can use one machine to treat the disc, one machine to treat adhesions in the nerve, bone and broken in the tendon, adhesions between the nerve and the fascia under the pec minor.
Yeah.
Nobody else can do that except for people that do FSM.
Yeah.
And so what did you do on your vacation? I swam in the lake. I got a hot stone massage. I went on a 4-hour trail ride, and I changed the lives of 4 people. I'm not sure which part of that was the most fun.
No, I'm laughing because earlier I had a bit of a break and I went for a little bit of a walk to get a coffee and to just get some fresh air. And this man was walking beside me. I know this is going to sound weird and this is going to sound creepy, but you do something very important. And I'm like, I do? And you're such a happy, confident healer. I can tell that about you. And yeah, I know. And I was like, just had my smile and I'm walking. And I'm like, even if this guy is weird, this guy is pretty accurate. And as I was walking, I was just thinking about the treatment that I had just given somebody, right? And I don't know about you, but I play it back in my head because it's more than just fixing somebody, right? It's because you are able to pull together so many aspects of their life that I don't think very many people tie together. So what I mean by that is when you're doing a history, and I was demoing something really quickly for a quote unquote tight hip or hip bursitis. And I was asking questions and the person's like, why are you asking that? I'm like, because we don't just settle for the muscle is tight.
Never tight for no reason.
But that very simplistic component of treating and assessing is now like a grain of sand in the big beach of FSM. And so I get it. It's tight. Why did it get tight? Whoa. Nobody's really asked that. It reminds me of seeing a functional medicine doctor for the first time and them asking, have you ever been anemic? Yes. Why? I don't know why I was anemic. Nobody ever asked me why I was anemic. They just threw iron down my throat when I was a teenager. So I think collectively we're getting better in some ways, like especially functional medicine and what we're doing. But it's asking the big questions. It's sitting down and looking at somebody and listening to their story because A, you care, and B, that's where the magic is, taking the history and taking the emotion and taking their occupation that they love. And I don't care if it's a professional athlete or a violinist or a mom that just wants to hold her baby again without cringing in pain. This is all part of the story that helps direct you. And that's what I fall in love with. So as I was walking and I was obviously like giving off some sort of like cool, healing, energetic, happy vibe, because I get it. Like I want to help somebody, but I want all that story behind it because.
And how about the word that you used was healer? When people say, I'm a healer, it's I don't heal you, you heal you. And the magic of it is that the frequencies, I'm a thinker.
Yeah.
I had my hands on somebody yesterday that had 0 extension, 0 flexion in her wrist, big knuckles here and here, She's had rheumatoid arthritis since she was 8. She's now 61. She has none of the deformity that you'd expect from rheumatoid arthritis. She has had the typical treatment, but I've never seen an RA patient that was so functional. And she uses her hands for a living. I took her, she said, my hands are stiff, my pain is a 5. So I ran the concussion in Vegas on one machine. And then I contact at her elbow and a contact around her hand. And I ran inflammation in the cartilage and inflammation in the synovium. And I said, what's your pain level? She said, oh, maybe 1, but they're very stiff. So what does stiff mean? I have a frequency for that. Scarring. So but the thinker part for FSM practitioners is what is scarred. So there's the joint capsule. There's the synovium. There's the periosteum was really tender, but the periosteum doesn't get scarred because she's been inflamed for 50 some odd years. The inflammation turns into calcium deposit.
Right.
So I ran 217 because she's 61 and she has long since passed 91, which is just hardening. And she's now on to ankylosing.
Yeah.
And I ran that in the joint capsule, the periosteum. And then you put your thinking head into Netter and you look at all the tissue. The flexor tendons have a little connective tissue band that they use as a lever arm to be able to bend your finger. If you inflame everything under that for long enough, it's going to get scarred. So I just think about the anatomy and what's wrong with it. What's wrong with the connective tissue that's scarred? A frequency for that. 13 or 77. So I did that, and all of a sudden her finger bent. What else is in this finger? There's nerves. So we did scarring in the nerves, scarring in the round tendons, scarring in the connective tissue, scarring on the joint capsules, scarring in the synovium, and then moved to the next joint and moved it slowly. That's the other thing. The class in Dublin was sold out. And they're all neuromuscular therapists for PTs or DOs. And they all said in unison, when I asked them, okay, what did you learn? They said, do everything more slowly. Anyway, at the end, she could squeeze her hand. Her pain was a 0. Then we went to her wrist. And it was the same thing, except there are 7 joints plus the connective tissue. And at the end of it, she had 5 degrees of extension, pain-free degrees of flexion. I didn't heal anything. I took knowledge of anatomy, the picture of the wrist and the fingers from Netter, and the frequencies on the list, and combine them to fix what was wrong. And yes, we end up healing people coincidentally, but I don't heal them.
No, but you teach people, and I look at healer as, even when I just do personal training or exercise therapy, I believe helping somebody move better is helping them to heal themselves. So I am a healing
facilitator. I like that.
And yeah, I agree that the healing it's not some magic device with some magic formula that just sounds a little bit too, I understand that component, but I like the word facilitator. And I think you've done such an incredible job of like I said, just sharing your knowledge to help all of us be facilitators of healing. I see a doggy coming in, or maybe not. Yes, I do.
There's a place. She figured out the door was open.
Oh, I just love her so much.
She's just coming along.
Just wants to say hi to everybody.
Mama's gone for 2 weeks. And that's every trip we're taking this year is no more than 2 weeks. Just
Yeah.
that she can't. Cool. Back to you.
Yeah. So what I really come to enjoy just as much as helping people is the teaching part of it. And doing these small kind of private trainings that I've been doing with small teams and groups and clinics is the reproducible part of it. And you've used that word so many times. And to me, that is the exciting part. It's not just me and my great manual therapy skills. It thing you can use this, and it's the way to think about it. And I know it's true when we get questions, like emailed questions. Someone has tight paraspinal muscles and blah, 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 blah. And then you ask right away, well, what are the discs like? What does the imaging look like? They haven't had imaging. The discs are fine. Discs aren't always fine.
What are their reflexes? What are their sensations? You can tell what the MRI is going to look like with patellar reflexes, upper reflexes. And then the reason you do the MRI is to confirm your physical exam and make sure that it's not worse than you think it is from a physical exam. The embarrassing part about being me is that it took me 23 years to figure out that I was teaching the wrong thing, that I was teaching frequencies instead of the fact that what we teach, you and I both, how to think about fingers, about the arm, about carpal tunnel, how to think about it when you have frequencies to use as a tool. It's a different way of thinking. And it makes it so much fun, at least to me.
Yeah. No, I want to touch on something super quick. Everybody that's listened to the podcast probably for a little while knows that I hate certain phrases. You and I both hate things like weak glutes and tight psoas.
Our role.
And I think it's really easy to just throw out those terms, weak glutes, tight psoas. There's a lot of models out there that tend to show us that our psoases, our hip flexors are chronically shortened because all we do is sit down. And yes, that is true, but digging at it with a utensil and trying to rip it apart with an elbow, it doesn't work. It's very kind of short term. So
the psoas is tight because you're sitting. Why is it that the frequency that makes the psoas completely let go is the frequency for scarring in the ureter?
Right.
There are people that sit a lot that don't have short and tight psoases.
Right.
So it can't be just that.
No. Here's my whole new kind of spin on the way I think about FSM. And I think we are constantly evolving. You and I are trying to teach it in a way that it's not so overwhelming and it's exciting, because it is new for people who have practiced a certain way for so long to just treat what they see or treat what they find or treat what they feel. The therapists that you saw in teaching in Ireland, they're not used to listening as much as they're used to telling with their hands and their pressure. So slowing down their manual therapy enables you to get that feedback and listen to what the tissue is telling you. So I am starting to look at it as, what is the short-term play and what is the long-term play?
Mhm.
And that's where multiple machines typically come in, because the short-term play should always be get the person out of pain. And sometimes that's the long-term play, but I think you and I can both agree we'll attack things from different angles. But I think you and I are almost always thinking first, the person's in pain, I need to get them out of pain. and then I will go.
Finished. But I did something new that I've never done in 30 years.
I'm going to give you a chance to share that, but I just want to finish my sentence with the short term and the long term, because I do think that helps, especially when you start using multiple machines. The short term play, get them out of pain. So maybe that is the custom care, the precision care on scarring in the nerve, inflammation on the nerve, 124, something. And then the long term play, that's what helps you generate, how did it get like this? So you don't have to have all the answers day 1, minute 5 of an initial treatment, but getting somebody out of pain, that is something that you can do relatively quickly while you're figuring out the bigger part of the story, right?
Exactly. And the other fun thing about it is that the frequency response will tell you or confirm what's going on. So one of the practitioners in the Dublin class had been using FSM, took a course from somebody else that wasn't me, and he said they were working on the shoulder, and they asked me to come over, and his shoulder was very anterior. And I to look right. So I distracted it and tried to glide the humeral head back into the, is it an acetabulum when it's on the yeah.
The glenoid fossa.
Awesome. And it didn't want to go. And I wasn't about to force it. And I said, what happened to your shoulder? He said, my bike and had an anterior dislocation. I said, there's no way to anteriorly dislocate your shoulder without tearing the labrum, or at least traumatizing it. So I ran the frequency, torn and broken, and I used meniscus, figuring it's roughly the same tissue as a.
Yeah.
And all of a sudden, the muscles in his shoulder turned to pudding, and the humeral head just went gliding back. It still wouldn't seat. I thought, is there any way to tear the labrum without causing trauma? So on spec, I ran 294, trauma in the meniscus / labrum, which is 214. And the humeral head just slumped the fossa, the anterior muscles. I don't even know how to describe it. All of a sudden, the deltoid was doing its job. It was back where it belonged. And I said, okay, when we were debriefing at the end of the class, just so you know about the learning curve with FSM, I've been doing this for 30 years, and that is the first time I've ever run that frequency combination in the shoulder. There's more to do. And he's a PT / neuromuscular therapist. And I said, so you know that what you need to do is strengthen the posterior muscles and keep the humeral glided back, keep treating the labrum under custom care. And you're talking 4 to 6 weeks, but you've had this for 15 years. So it's like not that hard, but just the concept that you could take the story, I anteriorly dislocated it. Almost everybody else on the planet would force humeral head back and start treating the ligaments and prolo them. And in our world, you just tell the labrum it's going to be okay. Torn and broken, poor baby, treat it for trauma.
But you're right. So I've been using trauma forever with athletes because it's the trauma that caused the tear. And I learned that the hard way of treating a labrum, especially like you said, I treat a ton of shoulder dislocation. And the labrum, as you said, it has at least some aspect of micro trauma, whether it's like a big fat tear that you're going to see. So like you said, it is impossible to anteriorly dislocate the shoulder or sublux it without the labrum being somewhat traumatized, somewhat torn. And it's funny when we see athletes getting an MRI after I've treated them, it's funny to hear when I send them and the surgeon will tell me that labrum was torn, but it is now healed. And I don't know how you do it, Kim, but it looks fantastic now. But it's not the one and done. So after it's quote unquote healed, until the mechanics are sound, stable, and symmetrical, you might have to go back and keep treating the labrum here and there.
Right.
If you think of torn and broken not as a macro torn and broken, like a fracture or a tear, but there's always micro trauma that's going on, especially in the rebuild phase. So like you were saying, the integrity of the shoulder is very little to do with ligament and labrum. It's a lot to do with the strength of the rotator cuff. And with that is proprioceptive feedback. And that is where like my hair stands on end, is when I get to treat with proprioception.
And coordination. The challenge is that this guy's been using his shoulder as part of his job for, let's say, 10 or 15 years. And the cerebellum said, okay, you want to do this. And it changes the order that everything fires in so he can get the job done that his sensory-motor cortex tells his shoulder to do. And the cerebellum says, okay. And he plays chess in his head. And then the cerebellum makes it possible to do that. But it's all capital on purpose.
Yes.
And so once we get the mechanics for the shoulder joint or knee or hip or whatever, then the magic is, like, for all of these patients that I treated in Austria, the magic was 40 and 89, stop being afraid to move it, and then tell the sensory motor cortex to forget everything it knows, and then tell the cerebellum to forget everything it knows, and then have them move it by increasing secretions in the cerebellum, the sensory motor cortex, so that the brain can get used to coordinating the new movement. It's not a one and done. They have to practice it, especially for athletes. It has to get into muscle memory. A concert violinist, it's moving so fast, it's in muscle memory. And I told her that the next day she was not allowed to play anything fast. You play something slow so your brain can get used to who your arm is now. That's the rehab process. Otherwise, the dysfunctional patterns will recreate the problem that was there in the first place.
Yeah. To capitalize on the slow. So we're talking about telling the therapist to treat slow. Now you're telling the patient to move slow. I think so much of what we do, to borrow the phrase, we blow through the stop sign. We get from point A to point B. We don't care how we got to point B. We just got there. So when you break down a movement pattern and you have a patient, it's an upper extremity test or a squat test, they're going to do it fast. They're going to do it bilateral and they're going to do it fast. And when you get them to do one side at a time slowly, there's nowhere to hide. There's not. And so when you do a bilateral squat, and then I'll say, why don't you do a one-legged squat? Oh, I don't do anything one-legged. You have to. We're not bouncing around on planet Earth, jumping from two legs. A walking stride is weight transfer left and right. I think the more functional we can get with breaking down a movement pattern and going slowly, you can see it, the patient can feel it, and then you can really see how much compensation took place to get them from point A to point B. We're all in this sort of survival game, right? It's just the matter of how fast and how strong we're in it. A single mom of 3 kids that just needs to keep working to put food on the table is not going to register pain or slow down the same way that somebody who doesn't need to get up and go to work does. The urgency of getting better is different with every demographic. But like I said, and you said, we have to just slow everything down to see it.
And see the connection. So
Yeah.
there is a reason that they spent 2 weeks, 5 days a week for 2 weeks, 10 days, 10 hours on the gait cycle. And
Mhm.
the gait cycle is heel strike to toe off to heel strike. That's it. When he told us what he was going to do for the next 2 weeks, my brain just went, you just, and then when you do the supine shoulder, and everybody in the class, and we had 10 tables, had adhesions between the lats and the long thoracic nerve and the serratus. So we went to each table and showed them how to release the lat with scarring in the nerve and separate the lat away from the serratus and away from the long thoracic nerve. And then I had to explain to the class why the next visit the patient was going to mention that their low or their hip was fucked. What? I said, look at where the lat goes. It's an internal rotator, but it attaches at the back. So
Right.
when you change how the lat works, you're going to change what happens at the low back. That's going to change how the glute works,
Right.
and that is going to affect either the low back or the femoral plexus or the hip. And because I say it's twice a week for 4 to 6 weeks. So what do you do? And I said, you treat what you find. So if what walks in the next day is the shoulder, you miss something, so you work on the shoulder. But if what walks in the next day is I have this funny pain in my head, oh, okay. Then you treat the psoas and the glutes. Because now that the lats can work more freely, the hip can extend more free. Does that make sense?
Yeah. Yeah.
The hip can extend. So what do you treat? What's next? Whatever walks in the door. And that's the magic. That's the magic, is the reproducibility, but you have a tool that lets you do things that create big changes in short period of time with very little effort on your part.
Yeah.
It doesn't take 3 months. It
No.
takes 20 minutes.
Yes. Before we get into anything else, do we have any questions? I just wanted to.
There's one that's,
Okay.
Louise, an acupuncturist friend is having a total knee replacement next week. Stop the bleeding. Recommendation series of frequency pairing as post-op days move on. In the custom care mode bank, there is a whole post-op suite, and there is post-op knee. Now, there's portions of the mode bank that I have to redo when I'm on my next 5-day break, but the post-op suite is all current. I've done that the last 2 or 3 years. So there's post-op knee, that is for a knee surgery with a knee replacement. I don't know if I have a specific replacement protocol, but the first 2 days, there's a lot of time spent on stopping the bleeding, torn and broken in the connective tissue, especially with a knee replacement, because they wrench it apart, cut the bone. You have to treat the bone, the tendons, nerve traction injury. You stop the bleeding, treat the bone marrow for trauma. And that's the first 2 days, especially. There's probably close to 60 minutes spent stopping the bleeding. By day 3, that's done. And you're treating trauma, paralysis, allergy reaction, vitality, torn and broken in every tissue you can think of. And that's pretty much why there's, I think, each of the post-op suites is day 1 and 2, day 3 through 7, 7 to 14, 14 to 21. So it's about a 3-week session for any post-operative. The end of 3 weeks, we've already done the impossible anyway. So it's fun.
And I would have to go back and look at it because some of the post-op protocols that are on the MoBank are fantastic starting points for any type of surgery. So whether it's hip or knee, like you said, they have a lot of commonalities between them. Like you
But
said,
you have to customize them.
and you can patch them together and move things around. Now, how long or how many days is the remove anesthesia on the, is it just the first day?
First or second day. Sometimes I actually leave it till the 3rd day.
Okay.
Because the brain fog isn't going to kill them. They need to be groggy so that they'll lay down and sleep more than usual because they need sleep. And then day 3, you put in remove anesthesia. And the thing is that I think there's a separate protocol for removing anesthesia because the anesthesia in the different post-op patients I've treated, it gets stuck in different places.
Okay, I was just going to ask you that because I was typically putting it in, especially for people who get nauseated after they wake up. I was putting it in right away on the first one, and that seems to help that demographic considerably. And I at first thought maybe it's a coincidence they just had a good anesthesiologist, but it's worked enough times with different anesthesiologists. It's not that.
No, it's the anesthetic agent and it's the patient's liver genetics. The nausea from anesthesia comes, as I understand it, from, so the anesthetic goes through the liver, and if the liver can't metabolize it, the anesthetic goes back up into the brain and ends up in the medulla, the barf center in the medulla, and the midbrain. And it's like chemotherapy. The nausea comes from the brain, not your stomach.
Yeah.
So you remove anesthesia from there. I hadn't even thought about the nausea part of it, now that you mentioned that. So when I redo the MoBank, I'll pay attention to that and make sure it's on day 1. Usually I remove anesthesia from the liver and the medulla and the midbrain and the cortex because what they mind is the brain fog. And then
maybe it makes 2 appearances, day 1 and day 3. Day 1 just the ones that get sick from it, and day 3 to actually pull it.
There's a good reason now that you mentioned it to put it in on day 1. It made me feel better, like I was less beat up. When I took anesthesia out, for me, it was stuck in my lungs. My lung burned, and Sonia was treating me after my gallbladder surgery, and she ran remove anesthesia from my lungs, and my lungs stopped burning. One patient, she would not wake up, like she was still out for 4 hours, and I was bored and lonesome. So I was treating her with a blue box, and I ran remove anesthesia from her liver. That didn't do anything. Her lungs, that didn't do anything. I ran remove anesthesia from the cortex, and in 10 seconds, she blinked and woke up. And different patients have been in different places. So maybe we should have a separate remove anesthesia or just do a drive-by because it doesn't take but a minute or 2. So you could put it on any post-op protocol on day 1 or 2. That wouldn't hurt. Okay.
Right. I don't know. Louise then just asked about pre-op. So for a total knee replacement, the name of the game for pre-op is just getting everything as strong and as balanced and getting the tissue as healthy and pliable as possible so it can have some wherewithal when it gets pulled apart and beat up. And like you said, especially in a replacement, whether it's hip or knee. So that's my jam, is doing what we call prehab. In the case even for ACL reconstruction, if they're going to do a hamstring graft, for instance, we want to get that hamstring and that tendon as strong as possible and get the quads, get all the surrounding tissues as healthy as possible before surgery. So any kind of pre-op setting, my brain automatically goes to just the health and the pliability of the tissue And I think it goes without saying, if they're nervous, helping to treat the nervous system, like all the things that I think no matter what type of surgery, we want to go into surgery as calm, as healthy, as hydrated as possible. So there are many factors I see already just floating around that we can help with, help support.
The one I would add is to take out scarring in all the nerves above and all the nerves below. Any injury that's ever happened where there's little adhesions on a nerve, when you start pulling apart joints to replace them, you're stretching the nerve, and every place that nerve is tethered creates trauma to the nerve and trauma to the surrounding tissues. It makes sense pre-op to take out the adhesions in the nerve and then restore the health for the connective tissue, especially, and blood supply and round tendon. And that's torn and broken and lots of vitality. How do you think of
Yeah, no, exactly. I'm just, like you said, with the nerves, that as soon as you had said, like, your cerebellum will never let you traction a nerve. And what the fallout of splinting and guarding to protect adhesions surrounding a nerve, just how catastrophic and the ripple effect that has with compensation. So you're absolutely right. Just thinking about anatomy above and below, keeping those nerves free. I think of just a ton of vitality, increasing secretions to the fascia, just making it a beautiful, fluffy, happy, whatever. But yeah, thinking above and below, and then with not even an extremity surgery, but visceral, surrounding neighbors. What's around it? What can we help with so that healing can take place?
thinking about visceral surgery? So I'm having a laparoscopic gallbladder surgery.
Right.
Well, everybody just thinks of, oh, they're going to put this little camera up there and do snap, and it's easy. And you think about where the incisions are, and the camera is a metal tube that big with instruments that come out the end of it. And they fill up your belly with air so that there's space, so that they can see what they're doing. And the surrounding tissues get traumatized. They go in through your umbilicus. So there's the omentum, there's the small intestine, there's the liver, there's the bile duct, the pancreas. So the gallbladder post-op include trauma and inflammation to those tissues. So you think about everything in 3 dimensions.
Yeah.
So and same thing with the knee and the hip. I love Netter.
Yes. It doesn't matter what volume you have, whether it's 1 through whatever version they're on now. It's our little like roadmap to the tissues. And I think it's just like the laminate is inspirational and the frequency tends to jump out when you need it to. Netter, and yeah, don't be afraid to Google something or open Netter, and like I will tell a patient, oh, I want you to just see what we're doing, and it has nothing to do with the patient. I see you're probably looking at a question too right now.
Sorry. Yes. I like being inspired.
Yes, I know.
So I OT with a goiter and practically remove it. It's like this poor woman, she had a goiter and the class was over and she was headed out the door. And I said, would you mind terribly if I can't stand? Would you mind just laying down for about 15 minutes? And it was amazing to see, hoping you'd bring it up in one of the podcasts. I may have missed it, but if not, could you recount? The first time, as long as it's a glandular goiter, and as long as you know that it's been imaged and it's not hot, so they know that it's not thyroid cancer, it's just a goiter. And the glandular goiter means that the thyroid tissue gets enlarged. There are collagen goiters that are like collagen tissue we don't have luck with. First time I ever treated a goiter was in 2002. It was a myofascial therapist group in Chicago. And this one woman volunteered. This was back when I did demos to begin with. And she laid down on the table and I went to work on her neck. The reason that she had no neck flexion was that she had a goiter the size of a New York steak on the front for me. And I was supposed to be treating her muscles. And I told the class, just pretend you didn't see this part. And I did the 58s to start with, and the thing just started to shrink. And then you do, what is it? It's inflammation in the thyroid. So you do inflammation in the thyroid. I mean, think through it. What is it? 58s are fibrosis. And then inflammation in the thyroid. And no, it has never caused a thyroid storm or anything weird. And then it's scarring in the thyroid and fibrosis in the thyroid. And you don't do anything except follow the tissue down with your fingers. And it just disappears. It is the weirdest, coolest thing you'll ever do because it's so easy. And the shoulder's complicated. The hip is complicated. The viscera is complicated. Goiters, I would stop strangers on the street and say, it's one of those. So, Diane, thank you. I'm glad you noticed. I forget to even talk about it. And in the core, it's buried in the visceral section. It's exactly what I just said. 58, 40, 13, 51, scarring, fibrosis, inflammation in the thyroid. And you just follow it down with your fingers. Oh, it's one slide out of 1,046 slides. So the fact that anybody remembers that goiters are easy is impossible.
I think, especially if you're new to treating and experiencing it, because it's subthreshold, because we don't hear the frequencies, feel the frequencies, there's a very small part of that bell curve that get completely stoned right off the bat. But something like a goiter or something that is very acutely and aggressively inflamed, where you don't see it actually shrinking in size, or a hematoma changing in color before your eyes. I think it's great that you can have a visual experience like that at a course, because then you can see it change before your eyes. And yes, there's much and there's range of motion.
Same thing with ovarian. You palpate somebody's ovary and it's the size of an orange, and it feels like a water balloon. And then you just run 40 and 7, inflammation in the ovary.
Yeah.
Tishner goes up. And the student that's got her hands on the patient goes, it's gone. There it is. Now, feel over here. If she had one cyst, she's had more than one. And when the cyst ruptures, it lets sticky stuff out. So now the ovary, feel that tight place. What tissue is under your midline? It's the bladder. That means that the ovary has rolled over and the sticky stuff turned to scar tissue. So now try running scarring in the ovary. And when it softens, it'll soften a millimeter or two, and then you pull it lateral millimeter or two, and then you wait till it softens a millimeter or two. You pull it lateral a millimeter. And those things are really fun.
Diane just wrote, she also started shaking uncontrollably, and you thought and fixed it. And she gave a yes fish shake. So the shaking, sometimes shaking does absolutely happen with FSM. I believe it was the sympathetics.
Yeah, it says 40 and 562.
Yeah.
Some patients say that. I hear it come out of my mouth, and
I know. And I was like, it's just the sympathetics.
Some patients, when they get, it's a guess, because the shaking is definitely sympathetics. And so we can quiet the sympathetics. The real question is, why do the sympathetics go berserk in the first place? And the only thing I've been able to come to, because there are certain fibromyalgia patients where you're doing 40 and 10, and the patient will start shaking about 40 minutes into it. And that's the point at which the endorphin have risen by about not quite 10 times, maybe 6 times. They double in the first 10 minutes, but then they go up really sharply after that. And my best guess is there's something about the endorphins going up so fast, or something changing so fast that the body perceives it as a threat. And the sympathetics fire. Because I ask the patient, are you cold? Okay, so it's 40 quiet synthetics. You can stop the shaking. They stop shaking. You keep doing what you're doing. They start shaking, and you just go back to 40 and 562. That kind of flexibility is what makes having a precision care worth the money. So you can just jump on.
I remember once, I want to say it was Roger Billica, but I could be wrong because I sometimes mix up what he says about, and no, it was him, because it came with the whole, sometimes you have to put in more good before you take out the bad. So we're talking about sympathetics, and he was saying sometimes you want to increase parasympathetics before you quiet sympathetics. Sometimes you need more parasympathetics.
Balance.
I always say it's like learning how to drive manual transmission when you learn how to put the clutch and the gas pedal, and it's that balancing act.
And these days, I cheat. I just let the vagus nerve do its thing.
Yeah.
Because vagus and the brain have constant communication with the body.
Yeah.
And I hardly run 40 and 116 quieting the immune system. Used to be standard.
Yeah.
And now even when I treat myself, I don't run 40 and 116, even though at my age, inflammation is the enemy.
Right.
I treat my vagus every single night, and I let my vagus decide how much inflammation I need. Unless my neck gets sore, at which point I don't care what the vagus thinks. I want my neck to stop hurting, neck pain, and we just...
Alarm's going off.
Is it really?
It is. And I knew this was going to be like that because we haven't talked in a while, and we've barely scratched the surface of my list, but that's okay.
Louise, the frequency for anesthesia is 19, and hang on to your list. I'm so glad you could get set up in the hotel.
And I wasn't sure how the Wi-Fi and how it's going to look or sound, but we're together and
looks great. It's good to see you.
Yeah,
It's good to see everybody else. Look at
yes. Hi, everybody. Well,
guys,
we're back. So I'll see you next Wednesday with the continued list. And we have a lot of questions too that came online that I wanted to chat about, but they'll just have to wait another week.
Yeah, it's so good.
All right, everybody.
Do good things, save lives, change the world.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.